So I would use the rest of this lecture hour to introduce Module 15A. The entirety of Module 15A are clinically related topics. And as such, they would better be taught in person rather than recorded and hosted on YouTube for us. So I will just give a brief overview. And if we still have time before the 10 o'clock that our lectures would end, we would go to Module 15B. Otherwise, it will just be Module 15A that we would do. So for subsequent lectures, having taken care of the clinical procedures that are in your curriculum that we have covered in the earlier part, we would just address the Module 15A. Then for those who joined last month, they still have about 2 or 3 procedures that has not been taught. So that would also be covered within the Saturdays that we have lectures. So Module 15A are for special topics and procedures, essentially some clinical procedures that may be required of you to perform as caregivers. So those procedures are vital signs. Then another topic that is not a procedure is ethics of caregiving profession, generally ethics of medical profession. Then some patients will have something called peritoneal dialysis that you may be the caregiver who would need to do such procedures at home. When you come to the hospital, you also get to see such procedures hands-on. Then some patients will need wound care and wound dressing done at home. Some patients will need catheterization. I know we've already had a lecture explaining catheterization procedure. For some patients, you may need to give intramuscular injection. That's injections that goes into the muscles. May go into the bum, may go into the shoulders, may go into the thigh. And some patients may also need intravenous injections or infusion. So a patient may already be on medications in the hospital and then is sent home to continue the treatment at home. So you may be the care personnel that will be instructed to administer such. So the theory is just to understand the safety around such procedures, such that when you come to the hospital and you see it being performed hands-on, you have a better understanding of what it is. Then in the event of a cardiac arrest, you may be the only medical person on site. Ability to do cardiopulmonary resuscitation, almost like you're trying to restart the person's heart, pending when help comes. Imagine your 70-year-old elderly person that you're caring for just slumps in the living room. There's no luxury of time to go and look for a vehicle to take him to the hospital. There and then in the living room, you may need to begin CPR for such a patient. Everybody should actually have at least baseline cardiopulmonary resuscitation skills. Then nasogastric tube feeding. Some patients with end of life, stroke patients, end stage cancers may even be frankly unconscious that they can't eat. So some of those persons will have NG tube. That's a tube that goes from the nose down to the throat. And Nurse Felix taught that a while ago. And then you may need to do the feeding at home. Then enema is done for persons who have been constipated for a while. So they just put the enema fluid in the rectum, that's through the anus into the rectum, with the hope and the aim of expelling the fecal matter, that is feces, that has been trapped in the person's intestine. So all of these procedures are some of the procedures that you may need to carry out for your patient at one time or the other, and a sound understanding of these procedures are essential. So I will just give a brief overview. We are not discussing it in details. We would now at later sessions, at later days, speak each of these topics one by one and cover them. It will also still be hosted on YouTube anyway, but I felt it's best if we teach it one-on-one before we go back and watch the recording. So vital signs, essentially that is like taking the basic parameters to assess your patient's well-being. I have an 80-year-old at home. The 80-year-old is hypertensive, is diabetic. You may be required to do the person's vital signs. So vital signs that you would be required to do would be majorly the temperature, the pulse rate, the blood pressure, the respiratory rate, and in some situations, you may need to do the patient's SpO2. SpO2 is arterial saturation of oxygen. Simply, it means the level of oxygen in the person's blood. So now, if I start with the simpler one, which is the SpO2, a patient that will need SpO2 done will have machines that look like this. They are called pulse oximeter. So if you have a pulse oximeter, nothing complex, it's just placed on the patient's finger, a finger that is not painted, a finger that does not have artificial nails, and you wait for readings. Normal reading should be 95 and above. But most of the patients that you will have at home that will need SpO2 monitored, many of them will have between 92 and 100. 92 and 100, you can just safely record it and you're good. If it begins to drop below 90, most of such patients will need oxygen. Most of such patients would also need some supportive medical care that may warrant you to reach out to your supervisor or the overseeing medical personnel of such a patient. So SpO2 is one of such. Then blood pressure is another reading that you may be required to do. So, like I said earlier, 80-year-old man is hypertensive, is diabetic. Likely, some of the care plan would include daily blood pressure reading. Daily blood pressure reading that you would assume to be normal for an 80-year-old man will be, it has a upper reading, it has a lower reading. So the upper reading comes from a range of 90 to 140. So that's the reading on top. The lower region is a range of 60 to 90. That being said, if I take the blood pressure of my 80-year-old patient and I have 140, 80, we are good. Or I have 140, 70, we are good. Or I have 120, 80, we are good. Or I have 120, 90, we are good. This will still be discussed in further details when we discuss vital signs as a whole. Such that if I then have less than 90, 60, something is off. One is I would not give my patients the antihypertensives that day. I will probably need to reach out to the caregiver. Or if I have more than 140, 90, something is also off. Maybe the patient has not had the medication or the medication is not being as effective as it should. Of course, I will document it as is expected, then probably reach out to the caregiver that my patient had a reading of 140, 150, 100. What do we do about it? So a sound understanding of arterial saturation of oxygen, which is SpO2 that I said is read on the fingertips with any machine like this, and the blood pressure is essential. Then of course, temperature reading too is also one of the vital signs that you may be required to carry out for your patient at home. Normal temperature is 36.5 to 37.2. Like I said earlier, we'll still discuss it more in vital signs. So my 90-year-old elderly patient, we've been taking the reading every day for the past 6 months, and we've always had a range of 36.5 to 37.2. But then I check it today and I have 38. Without being told, I know that my elderly patient is sick, and I know I need to get the patient to the hospital as soon as possible or get the medical personnel to the patient as soon as possible. Some of your patients too, you would also need to do daily weighing for them. That is common for patients with maybe any of the hand organs are beginning to fail, maybe heart failure, kidney failure, liver failure. So usually such patients would be retaining fluid, so their bodies are swollen. So when they are placed on any medical treatment, sometimes you may be given the instruction to weigh them daily, just to be sure that the excess fluid or whatever it is that is being monitored is being taken. So weighing the patient is also essential. There's no fixed weight because weight would vary based on the height, the genetics, and the body habitus of the patient. So what you're going for is, if my patient's weight was 75 yesterday and it drops to 70 today, something drastically happened, except if my scale is broken. So if it drops that suddenly, something is off. Even if the intention is that, even if we're giving like a medication that will move out fluid, mobilize fluid out of the patient, such that the excess fluid can be urinated and peed out, the patient may lose some fluid as is expected, and with that, some weight, but not as much as 5 kg. So just a sound understanding of being able to do the vital signs, and knowing that when something goes off your alert is essential. So vital signs is another things that may be required. So now ethics is a whole topic on its own. Inside module 15, it's a whole topic, and it encompasses the rules and regulations that guides medical profession as a whole, as a doctor, as a nurse, as a caregiver. And the main harms of ethics would include integrity, being moral, following the principles of healthcare profession, being honest, being right, being fair, being responsible, being conscientious, giving your patient a choice in how they will be cared for, then maintaining honor, valuing your patient and what you do. This again is a whole topic that will be discussed on its own. I'm just giving a brief overview. Now, peritoneal dialysis, like I said earlier, some of the patients you may be required to care for may have end organ damage, majorly kidney failure. So in such patients who have kidney failures, the kidney is not excreting the waste as it should. So two ways is some persons will be placed on hemodialysis. Hemo is blood. Dialysis is you're trying to wash out the blood. Simply, that's the simplest way I can explain it. Most patients who will be placed on hemodialysis will need to have the hemodialysis done at home. Sorry, done in the hospital. So such persons will visit the hospital twice a week. They are plugged to a machine and they get it done. But you may also be privileged to care for some persons who can afford or who have the means of procuring a dialysis machine at home. Usually that may be out of your job description. The one that would be within your job description is peritoneal dialysis. So medically, such persons have a tube that is inserted in the abdominal cavity, and then they go on with some special fluids that are called dialysates. You run the fluid into the tummy as if you're putting up a drip for a person. You let it wait for a number of hours, many times 4 hours, and you drain it out. It's usually repeated on a daily basis. Again, when you come to the hospital, hopefully you would get some hands-on experience. So that's another procedure that you may be required to perform as a caregiver. So wound care, wound dressing. Again, most persons who would have they would have caregivers at home. Many times, if the caregiver can be trusted to do a good job, will prefer to have it done by the caregiver rather than come to the hospital every day. Some of your patients that will probably have a wound that needs to be cared for, maybe a diabetic patient who has a wound. Usually, their wound takes a while to heal. Maybe a sickle cell disease patient who has a wound. Usually their wounds take a while to heal. I may just be a regular person who was involved in a road traffic accident, had a motor vehicle accident, was discharged, and then they have a caregiver at home. So you may be called on to help them take care of such wounds. Or it may be someone who had a surgery, and the surgery is taking some time to heal. And you may also be required to take care of the dressing of such wounds. So what we go for generally for wound dressing is to maintain asepsis. Asepsis is absence of infection. So you want to be sure that your dressing procedure, the dressing techniques, and the supplies you will be using will be sterile so that you do not infect the wound that is being dressed. So wound care and wound dressing is also another topic that we'll be covering in module 15. Catheterization, I think we already had a video that explained that, but it's also a whole topic on its own in module 15. The persons you may need to be changing catheter for many times are patients who are on chronic catheterization. So patients with BPH, that is enlargement of the prostate. It's common in men and in elderly men. It's a male disease, it's not a female disease. Or a patient with prostate cancer and maybe they are not ready for surgery. The patient does not want a surgery and prefers to be on chronic catheterization. So usually such catheters are changed every 21 days. Most times, once you already know the procedure, you've been adequately instructed and certified, you would be allowed to take care of it at home. So that's one of the procedures that as a caregiver, the onus may be on you to get it done for your patients. Then now, nasogastric tube feeding. I told you we put the tube through the nose. down to the throat, then it sits in the stomach. Most patients that you would need to carry this out for are many times end-of-life cases. End-of-life cases are cases that medically we would, speaking as medics anyway, we would say we do not expect a recovery. So the patient is going out, is going to eventually die over a number of weeks or a number of days. So the caregiver's responsibility then is like an hospice care, trying to make life comfortable for the patient in that period of time. But because some of them may be deeply unconscious and they cannot eat. And some of them may have, maybe like those who have cancers in the throat and they cannot eat through that places. So if they have a tube passed, many times they are on fluid diet. So the caregiver in most situations will be the one doing the feeding. So this is another topic that we would also need to have some hands-on to see how it is done. Then enema, as I told you earlier, I said commonly maybe anybody who is constipated for a prolonged length of time such that the fecal matter is not coming out easily. It's fairly common in elderly patients. So most of your patients at one point or the other in their life, they would be constipated. So you may be required to perform an enema. Enema, usually you need an enema bag. You will need the fluid for such purpose. You put the tube in the patient's anus, into the rectum through the anus. You run the fluid, you wait a while, you remove the fluid. And many times that softens the stool and allows your patient to be able to poo easily. These are procedures that are low risk in the sense that once the medical personnel has been adequately instructed, you cannot really injure your patients. That's what I meant by low risk. And because they are low risk, many times the caregiver should be able to carry out such procedures at home without much hassle. Okay, and the last one that I didn't discuss here is the administration of intravenous injection and intramuscular injection, which is also covered in this module. So I think that covers the first presentation. I want to ask if we have questions before I take the second one. The second one would probably take up to an hour or an hour and a half. And I think we have 30 minutes more now. Let me take questions. So that will probably call it a day and take the whole of the next topic at the next class, which is next month. Do we have any question? Does anybody have any question? Yes, please. Thank you very much. Go ahead, please.
Yeah, for the BP, ma.
Yes, please.
For the person is not is that doctor.
Yes,
but
please.
the BP read 95, is it 95/70? Is that normal?
95/70 is normal. Is normal. The upper reading, yes, upper reading is between is between 90 to 140. That's the reading on top. The reading like down is between yes, for adults. The reading on top is from 90 to 140. The reading under is from 60 to 90. That means 90/60 is normal. 95/60 is normal. 140/90 is normal. So the range is between 90/60 to 140/90 for an adult.
Okay.
Yes.
Okay. Okay. Thank you, ma.
All right.
Second question, ma.
Yes, please.
For a pregnant woman.
Yes, please.
Where I used to work then. So they used to do enema for them.
Yes.
Warm water with soap.
Yes.
For a fast newborn like that. Is that normally advisable too?
Medically, it's not advisable, but it's the rationale for them doing that is the uterus is just in front of the rectum. So in situations where they do such enema, as the intestine is moving in a bid to expel the fecal matter, it can stimulate the uterus. but it's not
Okay.
medically advisable. If uterus will contract on its own, it will. Otherwise, medically, the uterus should be supported with medications.
Okay. Okay, ma. All right. Thank you, ma.
Okay. So, any other question?
No question, ma. No.
Okay. It's all right. So I think we can call it a day. I'll host this one on the YouTube for us. This one is towards the ending of the program anyway. It's just that we want to take those lectures in person rather than record them. So
Okay.